Hello, hello. Good morning. It's my honor to be invited to give my talk at the AIDS Concern HIV virtual conference today. So my topic is sexualized drug use in Asia, experience from Taiwan. So this is my outline. We will first talk about sexualized drug use in the general population, then move to chemsex, a specific phenomenon among GBSM, gay bisexual men who have sex with men. And we will focus on crystal methamphetamine, which probably causes the most harms among people doing chemsex. Then we will also talk about potential interventions and harm reduction strategies. I'll share some latest data regarding chemsex we observed during COVID-19 soft lockdown last year. And finally, we will talk about the challenges we have now and what we should really think about doing in the future. So drug and sex are two biggest taboos in many cultures and societies, which also give us a great pleasure. Recreational drug use with or without sex is actually nothing new and pretty common. Many studies have shown that substance-linked sex occurs across all genders and all sexual orientations. From the annual survey for regular MDMA users in Australia, they found both heterosexual and LGBT users had similar rates of condolence casual sex while under the influence of drugs. In the 2013 Global Drug Survey, regardless of genders or sexual orientations, alcohol is actually the #1 drug used to have sex on, followed by cannabis and MDMA. At least 20% of each group reported to use drug with intention to enhance sexual experience. These small sachets on the right upper side of the slide is called coffee pack, but it contains no caffeine at all. Inside are a mixture of cathinone, such as methadone and ketamine, MDMA, and benzodiazepam, and they were used exclusively by heterosexual clients during sex in Taiwan. Dr. Mills and her colleagues have compared the recreational drug use among HIV negative and HIV positive individuals attending sexual health and HIV clinic from two large cross-sectional studies in England. It's called AURA and ASTRA study. So there are four groups: HIV negative women and heterosexual men in the AURA cohort, and HIV positive women and heterosexual men in the ASTRA cohort. So in her study, in all four groups, cannabis was the most commonly used drug, followed by cocaine, and recreational drug use was associated with condolence sex, depression, and anxiety. Chemsex, literally using chemicals when having sex, was used to describe a specific phenomenon where the sex between men that occurs under the influence of drugs taken immediately preceding or during the sexual session to facilitate or enhance the sexual experience. It has been called party and play, chem farm, high farm, ice farm, and other names on the geosocial dating apps in different countries. So different from the drugs used in heterosexual individuals, which we just introduced, substances commonly used during chemsex are crystal methamphetamine or ice, GHB, GBL or G-water, methadone in some countries, nitrites or poppers, and erectile dysfunction agents such as Viagra or sildenafil. Most chemsex studies are from North America, the UK, and Europe. Dr. Maxwell and his colleagues have performed a systemic review of the literature published between 2000 and 2018. For a total of 38 studies included in the review, the overall prevalence for chemsex ranging from 3 to 29%. Some studies suggested methadone was the most commonly used drug, while others suggest GHB or GBL, depending on the geographic locations. The prevalence of methamphetamine use, however, ranged from 3 to 22%. Regarding the prevalence of injection drugs, it ranged from 1 to 50%. It appears that methamphetamine is the most commonly injected drug. Several studies found that HIV-positive GBSM were more likely to have chemsex and more likely to engage in high-risk behaviors. However, HIV-negative GBSM also had a high risk of HIV and STI transmission when drugs were combined with sex. So compared to the Western countries, there are less data regarding the prevalence of chemsex in the Asia-Pacific region. Depending on the definitions used and the specific population assessed by the questionnaires, the prevalence among GBSM in our region varies. From the studies between 2013 to 2018, the prevalence of chemsex in Thailand is around 18%, in Vietnam 14%, in Singapore and Taiwan 9%, Malaysia 7%, and Japan 4%. One study from Australia showed 40% of the chemsex user use crystal methamphetamine in the past 6 months, and around 5% did slamming or intravenous injection of crystal meth. Some studies specifically describe prevalence of chemsex among GBSM living with HIV. Then the prevalence was around 30% in both Taiwan and Australia. Now we will focus a little bit on crystal methamphetamine, a potent CNS stimulant. It can be taken orally, snorted, smoked, or injected intravenously, or called slamming. The onset was quickest with smoking and slamming. So it just takes a couple of minutes to have the work into effect. Crystal methamphetamine releases dopamine and norepinephrine in the central and the peripheral nervous system and causes a myriad of physiological responses. Rush or flash is the initial response with euphoria and increased body temperature and heart rate, then followed by a high when the users become talkative, feeling overconfident and adventurous, and intensely focus on certain activities, for example, having sex repeatedly for hours. When there's no more rush or high, the users enter the stage of tweaking. When the users were deprived of sleep, being irritable and paranoid, feeling emptiness and craving. They can be hostile and dangerous to themselves or others at this particular stage. Finally, the user crash, become lifeless and sleepy. And after several days of feeling depressed and lethargic, the users may return to their baseline. Then the craving of using crystal meth kicks in again and start the cycle, which can occur as delayed as 3 months from the time of last dose. There are clearly several harms associated with methamphetamine use. Compared to other recreational drugs, Astra study from the UK again showed crystal meth is more strongly associated with riskier and condolences sex. When people overdose crystal meth, symptoms like hallucination, hyperthermia, or arrhythmia can occur and even threaten lives. The long-term use of methamphetamine will change brain structures and functions as well, causing addiction, psychosis, decreased attention, mood swings, and weight change. Slamming or intravenous injection of crystal meth may cause extra harm, such as local injection site injuries and infections such as endocarditis. Sharing needles will increase risk of bloodborne infections such as hepatitis C as well. And our colleague, Dr. Jawan, also found that slamming is actually associated with an increased risk of crystal meth dependence compared to other route of intake. So far, the intervention with the highest level of evidence for mass addiction is cognitive behavior therapy, such as the matrix model. It was first developed in the 1980s and it's proved to increase the interval with the participants staying in treatment and abstinent. It is a highly structured 16-week treatment comprised of many different kinds of therapies and drug testing. My psychiatrist colleagues always compare themselves to personal trainers in the gym, only that they work on the client's mind instead of their body. There will be very intensive courses teaching the users early recovery skills and relapse prevention, such as the thought-stopping techniques shown in the picture on the right. Other incentive-based interventions such as contingency management and the meter have also been shown to be effective among crystal meth users. There are many non-pharmacological intervention models in Taiwan. The most eye-catching one is probably this one, the Luder Association's therapeutic community. It was first established in 2019. In this therapeutic community, these highly motivated participants will need to stay in a quite structured setting, or actually a fruit farm in the mountains for at least several months. The participant will need to follow a very structured daily schedule full of physical activities, therapeutic sessions, and group discussions led by peer instructors and social workers. The participants will return to society once they become and remain sober stably. However, as you can imagine, it's a very labor-intensive model and can only accommodate a dozen of participants at maximum. They try their best to be self-sustainable, so you can also support them by buying their delicious peaches and persimmons online. Unlike heroin, there's no replacement therapy for methamphetamine. Only some pharmacological interventions have proved to be effective in addition to standard counseling. Mirtazapine is an antidepressant with mixed noradrenergic, serotonergic, and dopaminergic effects. In the double-blinded randomized control trial conducted among cisgender men, transgender men, and women who have sex with men, mirtazapine resulted in reductions in positive urine test results at 12, 24, and 36 weeks, shown in the figure on the right upper side. And also, it resulted in fewer sexual risk behavior. Long-acting naltrexone injection, which is an opioid antagonist given every 3 weeks, along with daily oral bupropion and a typical antidepressant. So compared to placebo, they proved to have better response over 12 weeks among participants with moderate to severe methamphetamine use disorders, as shown on the right lower side. So in most daily clinical settings, probably harm reduction strategies seem more feasible. People should be tested regularly with an HIV combo test to pick up acute HIV infection as early as possible. If tested positive, early initiation of HIV treatment and choose ART regimen, which suppresses the viral load rapidly with greater genetic barrier and with least drug-drug interaction will probably be ideal. For people testing negative, they should be offered individualized protection options such as condom loops, PEP or PrEP. In one study from Australia, it's shown that GBSM in intensive sex partying networks are increasingly adding PrEP along with other drugs. Screening other STIs is also important, especially those treatable and preventable with vaccination. Clear needle is crucial for slammers. Although we might have a long-established needle exchange program for hearing users, it may not be culturally attractive, accepted, and even utilized by the crystal meth slammers. And most clients with sexualized drug use do not go to traditional drug services or mental health clinics. They usually appear in the clinic for HIV or STIs. Our COMET study in Taiwan also found that ChemSex clients prefer LGBT-related or HIV-related organizations to traditional rehab centers. Therefore, it is important that we screen and help our clients in the setting with integrated sexual health services. One of the world-leading model is 56th Street, based in London. Our late friend David Stewart and 56th Street created a friendly space for all people using camps to talk about their conditions and have other services in the same building. Following this model, Hero Center was established in Kaohsiung, Taiwan in 2016, providing similar integrated services for the local communities. KPCC, a public STI clinic where I've been working in Taipei, also has psychiatrists and hepatologists clinic on the same floor, providing chemsex counseling and HCV treatment on the same day. Our colleague Dr. Strong has recently finished and submitted a review on chemsex and HIV infection to Lancet HIV. This is the Venn diagram in the review we love to use to demonstrate how different harm reduction strategies can be integrated and implemented at different timing of the chemsex session. Some are related to drug use, like intoxication overdose management, hydration and nutrition support. And some are related to HIV and sexual behaviors, such as needle service programs, condoms and lubes, PEP and PrEP, regular testing and treatment for HIV and other STIs. Providing information, education, and communicating with the user regarding these three different aspects are really the center of these harm reduction strategies. In the past 2.5 years, COVID-19 has impacted the community on their sexual and mental health greatly. In Taiwan, luckily, we have only imposed soft lockdown once during the worst outbreak of Alpha variant from May to July 2021. We conducted an online survey among GBSM social app users by the end of 2021 and asked the participants for changes they experienced during the soft lockdown. Among 6% of participants reported chemsex use. The majority had decreased frequency of chemsex or slamming during lockdown, regardless of their serostatus and PrEP use. Although there were very few people who actually reported increased frequency of chemsex and even slamming. Compared to participants without chemsex, there was no significant difference in the change of PrEP use, missing ART doses, number of sexual partners, and frequency of contactless anal sex, except for more HIV negative participants reporting both PrEP and chemsex use had increased number of sexual partners during COVID-19 soft lockdown. We haven't really looked at why it happened, but surely we'll do more analysis. Apart from some issues we have mentioned in the talk previously, there's still a lot that we can do now and immediately. We need to have constant financial support from the system to support sexual mental health services. We need to build international and multidisciplinary networks for collaboration and advocacy. We need to talk about sexualized drug use openly, non-judgingly with the communities and also with the general population so that we can bring down the stigma coming inside and outside. Finally, we should advocate together for changing drug and anti-LGBT laws and policies which are against human rights and kill people. So this is my take-home messages. Sexualized drug use occurs across sexual orientations and genders, although there is difference in substance preference. Chemsex, especially with the use of crystal methamphetamine, has emerged in a subgroup of GBSM globally and impacts the sexual and mental health of this population. And culturally sensitive and evidence-based interventions integrated with HIV preventive strategy should be developed and implemented promptly. I'd like to thank the communities who have always trusted us, inspired us, and supported our studies. I also like to thank Dr. Su and Department of Public Health in Taoyuan for supporting Asia Pacific Chemsex Symposium for the past 3 years, which had a great dynamic of exchanging experience with the first-line worker and also the users. My amazing staff, Huangdi, Xiaozhu, and Oscar. Many thanks to Jawan, Carol, Howie, Poya, Alex, and Adam for their support and inspirations. My gratitude to Dr. Isaac and Dr. Fritz for the inputs while preparing this talk. Thank you very much.